Today's session is going to be about hacking the coverage evaluation survey for enhanced decision making. Just confirm, Erica, that we're good on you guys can see the presentation? Okay, thanks. So the kind of overarching research question that we set forward for this session was about how we can use the existing coverage evaluation surveys, or CES, be adapted to collect necessary information to understand how to strengthen MDA, evaluate MDA implementation approaches, and better understand population knowledge, attitude, practices, which may impact research program targets. So we have three main objectives today, which we'll hopefully hit by the end of the session, to understand the ongoing adaptations to standard CESs to better provide information for control or elimination programs to improve MDA, provide new ideas as to how the CES could be adapted for programmatic needs, and finally identify the most important operational research gaps that need to be answered to further improve the CES. So the overall arching context is the data provided by the CES is increasingly important as country programs approach elimination. Districts with persistent and recrudescent disease face unique challenges and need more information for decision making. New interventions like biannual MDA for trachoma need platforms to evaluate their impact and determine subsequent programmatic adaptations. Just before we launch into the more formal presentations, I did want to acknowledge just a lot of people who have been involved in this activity and also introduce myself. So my name is Clara Burgert. I'm the senior epidemiologist on the Act to End Entities program funded by USAID. And there's a lot of people here today that are going to present, but also a lot of other individuals who contribute to the CES work that we'll be discussing. Obviously, individuals, households, and communities who participate in the surveys and countries, the field teams, supervisors, program and MOH staff that lead the CES activities. And then a special thanks to my current and former RTI colleagues who have helped take our CES activities to bigger and better places, including Maggie Baker, Katie Zerhoff, Molly Brady, Jeremiah Ngandi, Elizabeth Sutherland, Brian Fuller, Diana Liu, and Alex Jones, some of whom are with us today. And of course, the presenters. So today's session, we'll have some quick presentations around what the standard CES looks like for those of you who are less familiar with it. And then Erica will present around kind of questionnaire expansion. Joyce will present around sampling, and Dr. Clara Jones will present around qualitative work. Please add your questions in the chat as we go along so that we can capture those. We'll have a Q&A session following that. We'll then introduce our roundtable round robin breakout rooms, and then we'll have the round robin session, and then finally we'll have a quick wrap up with next steps. So to launch into kind of the standard CES, hopefully many of you are familiar with it and you came today to learn about all the things that we have all done to hack it, but just to make sure we're on the same page. So kind of a summary of the survey can be found in the Preventative Chemotherapy Tools for Improving the Quality of Reported Data and Information Guide from WHO that was published in 2019. The main purpose of a CES is to validate the reported coverage and to obtain statistical point estimates and be able to estimate also the confidence interval potentially. Usually the implementation unit or district is the level at which the survey is representative. The sample size is around 1,700 individuals, give or take. The sites visited is 30 clusters typically. And the timing should be within 6 months of MDA, but we all know, of course, that it should be as soon as possible after the MDA to have the best recall information. So a classic use of the coverage survey is to validate the reported coverage rates, both reach and adherence, to identify reasons for non-compliance, to detect problems with supply chain and distribution systems, and to measure coverage in specific populations, for example, age, sex, rural, or urban areas. And then also to provide an opportunity to measure other population attributes. And this is certainly the space in which we have looked to expand and see what other information could be gathered in the CES survey. So a quick overview of the sampling process. We have a survey area, typically a district or an EU. The subunits are going to be clusters or enumeration areas, villages, localities, depending on how the country does their sampling. And we will do a systematic selection of 30 subunits using a population proportional to estimated size sampling method. When we reach each cluster, they'll be segmented or broken into units of about 50 households. And one of those will be randomly selected to be the target subsection or segment. And within that, a fraction of households will be visited. And approximately 12 households are the typical kind of target within a segment. And then finally, all individuals in those households will be asked to participate in the survey and answer the coverage questions, as well as any other questions that are included. So some of the example of the standard questions that might be in a questionnaire, and this is what was included in the WHO guide: some basic demographics, sex, age, time, resident at time of MDA. There's also the possibility to have a proxy respondent if the individual is not at home at the time of the response or is underage, and then level of education. And then the key questions, of course, about if someone gave them the medicine at the time of the MDA to treat the disease, why, and if not, why they didn't receive it. If someone swallowed the medicine, and if not, why they didn't swallow it if they received it, and why they did swallow the medicine if they swallowed it, and if they swallowed it in front of the person that gave it to them. So then a DOTS level of questions. And then potentially who gave them the medicines, if there were any side effects experienced or severity, and the severity of those side effects, and if they were aware of the MDA before it happens, as well as potentially MMDP questions about morbidity, so LF questions, for example. So I'm going to throw it over to our presenters who have pre-recorded their presentations. And here the goal is for us to understand some of these adaptations that have been done by the standard, from the standard CES. And please, again, include your questions in the chat as we go along, and I'll see you after the presenters. Thanks.
Hello, my name is Erica Shoemaker, and I'm a Senior MERLA Specialist at RTI International. I'm currently working on the USAID-funded Act-to-End NTDs East program that supports 13 countries in the control and elimination of PC-NTDs. This presentation will focus on CES questionnaire adaptations that ACT East has helped to implement across the countries we support. As Clara described earlier, the guidance from WHO on the coverage evaluation survey questionnaire is limited and largely focuses on validating reported coverage. We have found that districts with persistent transmission are often facing unique challenges and benefit from questions that are designed to specifically address those challenges. ACT East has worked with host governments across several of the countries we support to implement questionnaire adaptations, and those countries include Haiti, Mozambique, Uganda, and Tanzania. The first adaptation I would like to discuss is the development of separate household and individual questionnaires. The WHO CES questionnaire lacks the ability to capture non-responses, refusals, missing individuals, or missing households, which makes it difficult to determine an accurate non-response rate for the survey. The advantage to having a separate household questionnaire is that the survey team has a dedicated place to record data on households that have no people at the time of the survey or households that refuse to participate. The household survey also collects data on the sex and age of all of the occupants, which can later be cross-checked with the individual survey responses to determine if there are missing participants. The individual questionnaire asks the participants if they are responding for themselves or as a proxy, and also tracks any individual refusals for the survey. The two surveys together provides a better picture on non-responses, refusals, or missing people. It ultimately provides us with better data on who is missing from the CES. Another adaptation that we made from the WHO questionnaire was to expand on the background or demographic questions that we asked participants. We added questions on socioeconomic status and access to WASH into the household questionnaire, and then included questions around education and literacy, occupation, religion, and ethnicity into the individual questionnaire. This gave us a better idea of demographics in the district, or at the cluster level, and allowed for improved social mobilization messaging that could be targeted to address the needs of specific groups of people. In the individual questionnaire, we added a question to assess a person's historical treatment status. We wanted to use the CES to identify people that had never participated in an MDA. So we added one question: how many times have you participated in MDA? Participants can select never, one time, or more than one time. The limited answer choices allow us to focus our analysis on individuals that have never participated in an MDA and also reduce recall bias. This question is often analyzed in a variety of ways, including by age, sex, location, level of education attained, occupation, religion, and ethnicity. This helps us to better understand the demographics of the people that have never participated in an MDA. We can use that information to develop targeted community education programs to expand MDA treatments to more people. To the individual questionnaire, we added questions around side effects. If participants indicated that they ingested the drugs, we ask a series of questions to better understand if they had any side effects and how severe those side effects were. Some of the questions are: did you feel sick because of swallowing the drugs? Where they can answer yes, no, or don't know. We ask them to list symptoms or conditions they experienced after taking the drugs. And the photo on the screen shows some of the response options for that question. And that can include headache and stomach ache to more severe symptoms like difficulty breathing. If participants indicate that they did not take the drugs, we ask a follow-up question: why did you not swallow the drugs? Participants can provide a range of answers, but one choice of interest is afraid the drug would make me feel badly or is dangerous, where we can determine how many people chose not to participate in the MDA due to fear of side effects. The information collected on side effects allows us to determine more effective social mobilization messaging and to help inform CDD training and education so that they are better equipped to answer questions in the field. We have also adapted the questionnaire to assess for our participants' knowledge of the disease. This includes their awareness of the disease in their community, whether the person feels like they are personally at risk for the disease, their knowledge of any morbidities associated with the disease, where we ask the question, have you ever seen someone with the disease? And for LF specifically, we can add questions that ask if a person has hydrocele or lymphedema. When we have a better understanding of a community's awareness and knowledge around the disease, we can determine if we need to develop better community education strategies or outreach, determine social mobilization messaging that addresses gaps in knowledge, and for LF, help to provide estimates for hydrocele and lymphedema in an area. Questions around population movement, especially as it relates to mobile and migrant populations, has become more of a focus across ACTI-supported countries, particularly in areas of persistent transmission. Population movement can be assessed on both the household and individual questionnaires. The questions that are asked on the household questionnaire include: in the past 1 year, did your household as a group live and stay outside of the survey location? If the person answers yes, then we also ask, what is the main reason that your household lived outside of the survey location during the year? Answer choices include tending livestock, fishing, agriculture, business, other, or don't know. We follow up these questions by asking if any individual household member lived or stayed outside of the survey location. Asking these questions in the household questionnaire helps us to avoid missing anyone that may not have had the opportunity to respond during the individual interviews. Some country programs also opt to add more specific questions around population movement into the individual questionnaire. Understanding population movement is incredibly helpful in planning for future MDA interventions. If the data indicates there are mobile or migrant populations, one key use of this data is determining an ideal time for the MDA so that we can reach as many people as possible. The data has informed other interventions that include coordinating MDA across country borders to ensure that migrating populations can receive the medication no matter their location. In coordination with national programs, ACTIS has also helped to develop more targeted questions that are specific to a particular country context. Some examples of these questions are asking participants where they received the medication, if it was through a door-to-door distribution, or if they received it at a drug post. Data from this question is helpful in allocating resources for future MDAs. We've also developed questions around country-specific improvements that were implemented during MDA. In one instance, snacks were distributed during the MDA in hopes of cutting down on the number of people refusing to take the medication. During the CES, we asked participants if they received a snack along with their MDA to help evaluate the reach of that particular intervention. There are also questions around trust, including who gave you the drugs and who would you trust to give you the drugs, which evaluate if the CDDs are trusted in the community. This data is used to determine if different social mobilization messaging is required to increase trust, or if we should consider adding someone like a health facility worker as part of the drug distribution effort. Now I want to share a few lessons that we've learned over the course of making adaptations to the CES. The first is that we recommend using electronic data capture for these surveys. EDC improves data quality, and the ability to include skip patterns helps our survey teams use their time more efficiently. In general, we have found that questionnaire adaptations are cost-effective because little, if any, cost is added to the survey. However, developing new survey questions or agreeing on which survey questions to add takes time, so it's important to make sure that all stakeholders are involved early in the process. For questions that are frequently asked across the countries we support, we've made an effort to standardize the survey questions and responses. This allows for comparisons within a country, between countries, and across diseases. Lastly, if you are going to be adapting questions or drafting new questions, it's important to have a data analysis plan to ensure that the data from those questions is analyzed and used for programmatic decision-making. I would like to thank the Ministries of Health, in-country teams, survey teams, and community members that contributed their time and resources to these adaptations, as well as USAID's support for the ACTA and NTD's East program led by RTI International.
Hello everyone, my name is Joyce Achan and I work with ACTA and NTD's East in Uganda as a senior management specialist. I'm here to talk about coverage evaluation survey sampling methods adaptation in Uganda. We carried out trachoma surveys in 4 districts that had TF prevalence of greater than 5% amongst children aged 1 to 9 years old. These surveys were carried out in the year 2020 in Moroto and 2021 in Abilatuk, Amdat, and Bulisa. As you can see from the map, Bulisa district is found on the western side of Uganda, bordering Democratic Republic of Congo, while Moroto, Nabilatuk, and Amdat are found in the Atekel region, bordering Kenya. We chose these particular districts mainly because of either recrudescent or persistent TF prevalence. We had earlier had MDA adaptations that included tracking, registering, and treating mobile populations. We therefore wanted to assess coverage using an oversample. Our key objectives were 1, to estimate preventive chemotherapy coverage and compliance, 2, to validate reported PC coverage, and 3, to identify contributing factors for compliance and non-compliance. So what were the sampling methods that we used? Our oversample of the target villages of interest included villages with high disease prevalence, those with low reported MDA coverage, those with either migratory or pastoralist populations, and villages that were found in hard-to-reach areas or peri-urban and urban areas. Our approach to sampling included a standard population proportional to size, and this is where we selected the 30 villages for our main sample. We then had target villages that were not part of the main sample identified. From these target villages, we selected the 10 additional villages that we included in our oversample. And this is what our results showed. From the map on the left-hand side, Amadat district had coverage of less than 80% in the target villages. Most of these target villages also reported coverage evaluation results of less than 50%, as you can see from the red boxes. When we come to Moroto, in the middle, we can see a large proportion of Moroto district had MDA coverage of less than 70%. And from this map, we can also see that a number of the target villages reported coverage of less than 50% from the coverage evaluation survey. When we move to the map on the right-hand corner, this shows a map that has a typical urban area. In this urban area, in the middle of the map, the MDA coverage was less than 50%. And the TF prevalence was also greater than 5%, while the coverage evaluation results showed that the coverage was less than 70%. As we can see, generally, there's a relationship between the MDA coverage, TF prevalence, and the results from the coverage evaluation surveys. So what do we learn from our oversampling? The oversampling has allowed us to target culturally acceptable sensitization and mobilization strategies. And this has mainly worked for specific target subpopulations, including migratory populations. The main reason for non-compliance from these populations has been that the distributor did not come to the house, or the household members were absent during MDA, or they were just not aware of MDA. We intend to use the oversampling approach in future. However, we will have other categories for our target villages, and this will include border or non-border districts, as we've realized most border districts or villages generally have low MDA coverage. The other consideration we shall make is to target villages with minority ethnic populations that tend to miss MDA. Now, for those who would want to use the oversampling method, we would recommend having target villages with limited access to facilities, since most communities depend on health workers for health education and sensitization during MDA. We will also recommend exploring reasons for compliance and non-compliance in the same subpopulations. I would like to thank individuals, households, and communities who participated in the CES, field survey teams and supervisors, Ministry of Health Uganda, including Gilbert Bayenda, and the district local governments of the 4 districts. Thank you.
Hello everyone, I am Clara Jones from the Ministry of Health Tanzania, working as the OncoSecurity focal person. I'm going to take you through the use of qualitative methods in coverage evaluation surveys in Tanzania. We conducted an enhanced coverage evaluation survey which involved collection of qualitative data in Mahenge focus in November 2021. This was purposefully done in this focus. Mahenge, as you can see on the map, comprises of 4 districts, and it has been on MDA since 1997. So as of 2021, during which when we are conducting the coverage survey, a total of 23 rounds of MDA have been provided, and the reported coverage was up to 85%. However, regardless of these high reports of MDA coverage, the focus was seen to have ongoing transmission of onchocerciasis. The epidemiological evaluation survey indicates that there are still some evidence of areas where there is transmission going on, regardless of the number of MDAs which has been implemented, as well as the reports which has been reported, which is above the threshold. We had three major objectives of the survey. One was to validate the reported MDA coverages. Two was to assess knowledge, attitude, and practice related to onchocerciasis MDA among community members. And three was to ascertain challenges related to MDA from community drug distributors, frontline health workers, and district NTD teams. And the third objective was the one which adopted the qualitative method. So the survey had two different components. The first component was the quantitative data collection as a typical coverage evaluation survey, and the second component was adding the qualitative data collection. The quantitative data collection, a cross-sectional cluster randomized design was implemented using the WHO guideline for coverage survey of 2019, and in this component we sampled a total of 30 villages in each district using the probability proportional to estimate the sample size. And on the second component, the qualitative data collection, in each district, 3 hotspot villages were purposefully selected, and we had the following criteria for selection of these villages. First of all, we are looking at the villages which reported the higher prevalence in the 2017 OV-RDT survey, where we wanted to ascertain the challenges to MDA in these villages. But also we are looking at the villages with consistent low MDA coverages, and also the villages which were identified as first line during REMO. A CES adaptation method which were used in this method were one, in-depth interview with district NTD team, and this included the district medical officer, the NTD coordinators, and also the district pharmacist. We also conducted in-depth interview with frontline health workers at the health facility level. We also conducted in-depth interview with community leaders or influential personalities at the village level. We also conducted focus group discussion with community drug distributors, and this one had a size of 8 to 10 participants. And also we conducted focus group discussion with community members, and with community members we tried as much as possible to balance the gender. Therefore, we were enrolling equal number of male and female in each village. The findings from this survey is that, first of all, with the quantitative part, we did not validate the reported coverage because there was a significant gap between the reported and surveyed coverage, focus-wise, as you can see on the graph. And also on the qualitative component, we had findings which we grouped into 2 categories. First of all, we had those findings which were programmatic related, and also we had findings which were community related. For the programmatic related findings, it was observed that there was inadequate coordination between the district and the CDD. Also, it was reported that CDD do not follow the recommended community-directed treatment with ivermectin approach, and also there was insufficient mobilization and sensitization prior to MDA, thus many people were not informed of the ongoing activity. And it was observed that there was discrepancy in the use of the denominator when calculating the MDA coverage. Also, it was on the Community Now issues, it was reported that there was low risk perception among community members. Some hamlets were left out of the MDA consistently, and there were some refusals due to misconception, and this also included mistrust of the CDD. The lesson learned and way forward as a program, we learned that adding qualitative component helped the program to identify programmatic and community issues which could not be picked in the conventional CES. For instance, the need to revise the CDTI approach to suit the time. And also the way forward is that the program plans to adopt qualitative data collection during CES in areas with persistent onco transmission, and this will help the program to devise the mechanism to solve those challenges. And also the program plan to enhance supportive supervision by using the WHO supervisor coverage tool during MDA. We conclude that adapting qualitative data collection in CES is important to help program identify specific issues related to specific community. Therefore, we urge all the national programs facing last mile challenges in elimination of NTD to consider making use of the approach. We would like to acknowledge all the participants as well as all the partners who have been working with the NTD. Thank you.
Thanks, Erica, Joyce, and Dr. Clara for your presentations. And thanks for all of you engaging in the questions in the chat. I'm going to hand it over to Karthima Raman, one of my colleagues at RTI, to lead us through the questions. Please continue to add them as well. So.
Thanks, Clara. We have several different topics for questions within the chat, and I invite you to continue to add them through this discussion. We can start with a couple questions related to validation in surveys from Michael and Scott. So questions are, have people considered looking at, for example, urine/DBS based analysis of drug metabolites so that we can get actual measures of drug participation and then more accurately measure coverage and cross-validate the accuracy of patient reports? And the second question being, have you worked on validating the historical MDA question at all, maybe through logbooks or some other form of administrative records? So I'll direct this question to our presenters. Maybe Clara, you can react
Thanks,
first.
Karthana. So to date, we haven't done either of these methods, though I think that it's quite an interesting idea. And I know there was also a comment in the chat from Ariana Means mentioning some work that was done by DWORM3 in this space as well. I think these are great contributions that we could hopefully add to our Easy Retro boards coming up as some areas to continue to explore or use in the future.
Thanks, Clara. Invite anyone else to respond or ask any additional follow-up questions. If not, we can go to our next question related to population movements. So Diana asks, it might be interesting to ask if that population was treated elsewhere within the country to see if they were captured in a different district. That would be interesting to see how if numerators and denominators are being differentially affected by such movement. So I'll direct this to Erica.
Yeah, thanks, Karthana, and thanks, Diana. I think we are sort of experimenting with questions around population movement, especially in the individual questionnaire, looking at providing participants with lists of districts and wards where they may have been traveling to get a better idea of where they received the drugs and then where they moved to. But yeah, that's kind of like an ongoing area of investigation for us, and definitely looking into it, and hope to hear more discussion about mobile and migrant populations in the breakout rooms as well.
Thanks, Erica. And Diana just noted that Act West is also asking questions in their CES as well. So looking to continue that discussion. Another question from Scott related to what effect does targeting or oversampling have on analysis? Likely one would need to move to a survey weight approach as opposed to a self-weighted design, correct? And this question is for Clara.
Yeah, so the analysis of the CES for the 30 cluster design is, as mentioned, self-weighted, and so you can produce confidence intervals around the coverage estimate that way. What we've been doing is just splitting kind of the survey, so creating the coverage estimate comparison that would be used for comparing to the reported coverage from those original 30 clusters. And then comparing if, for example, the original kind of randomly selected 30 clusters as compared to the purposefully sampled 10 clusters are the same or different coverages. And that's also helps us, better understand the data. So really that's kind of the extent of the weighting that's needed in the analysis. Is just we've been kind of stratifying the analysis and looking at the two groups separately. But certainly there could be some more analytical work that could be done in that space, but we haven't gone there.
Thanks, Clara. So we can go to a question from Mike and a follow-up question from Louise as well. Do you see a trade-off / diminishing returns when adding more elements to the CES? Does it make it more cumbersome or take more time? And Louise asks, I wonder whether increasing CES questions leads to reducing participation in the survey itself. Erica, Clara.
Yeah, I think that's a really good point, and I think that increasing the length of the survey, there have been concerns around reducing participation. However, I think that the idea is that you would only add in the components of the survey that meet your survey objectives. So whatever your particular country or district is currently wanting to find out more information about, you'd add in just those components. And I will say, yeah, adding in components is gonna have a time and cost factor, but depending on the situation, we found them to be worthwhile.
Yeah, I think jumping off of Erica's question, because of the way the skip patterns for these surveys work, like not everyone is ending up getting all the questions typically because of who's answering, if it's a proxy or not a proxy, if it's a child or an adult. And so the actual additional time, as we've estimated, is actually quite, relatively speaking, small. And we still remain, in most cases, being able to do a cluster in a day, which is kind of the typical approach for a CES. So we haven't found a massive additional burden, though certainly that can happen and something to watch out for. There's a follow-up question from Kevin around kind of the also additional complications of the analysis, which is absolutely true. And I think, again, this comes to the point about making sure that you're asking questions that you plan to analyze and you have the sort of analysis plan laid out and as Erica said, your survey objectives. So it's not that you add everything in the kitchen sink into your questionnaire, but that you're doing it in a purposeful way.
Thanks all. I also want to read out a response from Nirav in the chat related to the trade-off, as enumerators need to get through a certain number of surveys per day. But the bigger limitation being that surveys are typically powered for certain specific questions, such as offer the drug or swallow the drug, so we can lose analytical power if additional questions aren't formulated very carefully. Thank you for that as well. So we can go to another question. On can we learn more about the data processing time analysis needed with the qualitative work in Tanzania? That looked like a lot of focus group discussions, which require a lot of work transcribing, coding, etc. Would it be difficult to turn this around in a timely manner programmatically? This is a question from Scott, and I'll direct it to Dr. Clara Jones.
Thank you very much, Scott, for the good question. Yes, it was. It wasn't that, I wouldn't say it was really much of adding time for the analysis, because in our case, we just did the focus group discussion in the first-line villages. Therefore, we had in each district, we had like 6 focus group discussion. 3 was from the community members and 3 from the CDDs. And actually, the additional information was derived from the in-depth interview with frontline health workers. And for the processing, for our experience, because this was the first time, during the planning, we estimated that we were going to do the processing within 2 months. However, it ended up to 3 months. So by end of 3 months, we had the first draft of the report, and we started working on those preliminary findings to improve the upcoming MDA. So for us, it was really a good learning experience, and we didn't see it much given to the importance and also how it helped us to improve the MDA. So in terms of timing, I would say we were okay, because in 3 months' time, we already had the first draft of the findings. Thank you.
Thank you, Dr. Jones. We're at time now for our question and answer period, but I know that there's several questions we haven't had a chance to get to. Hopefully we can continue these discussions within the breakout rooms and then follow up after the session as well. So turning it back over to Clara.
Great, thanks. I think we can take maybe one more question, and I'm just seeing a little bit of back and forth in the chat, and great, thanks everyone for engaging there, and we hope to continue that conversation, as Karthana said. I think Joyce has also responded around kind of the timing, so thanks, Joyce, for engaging around the extra time, and I think one of the things that we talked about, kind of the time, was once we're already in the field. So in the scenario that Joyce is responding to around adding clusters, for example, once we're already in the field, the cost differential of adding 1 or 2 clusters was small compared to needing to go back for another kind of survey or intervention in the future. So that's how we approached that particular component. So I'm going to take us over to getting ready for our round robin session. Let me share my screen again. So here are the ideas for us to provide new ideas, and many of you have already kind of engaged on that. So new ideas or questions around the old ideas that we presented. And so we're going to use Easy Retro, and hopefully many of you are familiar with it. We've already pre-populated some of the things that were already identified in the previous presentations today. And then each round will have kind of a board to add your own new idea or a question. And you can also upvote any new existing ideas by pressing on the thumbs up sign if you think it's a particularly good idea or something you want to engage more on, and then also add questions or comments there. So hopefully this is something you're all familiar with. And how we've set this up is that you've been assigned to a room, so room A, B, or C, and you'll get to engage on all 3 of the questions. We have about 10 minutes per round. And the moderators will move rooms. So you as a participant will stay in your room, and myself, Karthana, Erica, Dr. Clara, and Joyce will be the ones moving around, and hopefully the technology will work for us to engage with you around the questions. And we'll share the link to the Easy Retro board for each question as we arrive in your room. So hopefully this will be straightforward enough, and we look forward to wrapping up after this time. So there's approximately 10 minutes per breakout, and let's get started. So please send us to our breakout rooms. We're getting everyone back from the breakout groups. I hope that even though they were pretty rapid fire, that you felt like you were able to add some comments and start some conversations. We're going to do a quick review of kind of the main salient points that came out of those groups as the beginning of our wrap up. So I'm going to send it over to Karthana to get us started with that.
Sure, thanks, Clara. So just wanted to highlight some of the key points that came out of our retro board here. We had some really good discussion in our last breakout room about standardizing the interview questions and standardizing the ways that questions are asked by interviewers, and addressing that during training, but also thinking about the way that questionnaires are translated into different local languages and ensuring that we're able to validate the way that the translation happens in those languages as well ahead of the MDA. In some of the other groups, we talked about responder fatigue, interviewer fatigue. How do we strike a balance with the number of questions are asked within households? We had some great ideas about including questions on the use of dose polls, including questions about disabilities, including questions more about social mobilization and sensitization activities. Joyce, do you have anything to add from our group?
Thank you, Tana. The other thing that the group discussed was looking at attitudes of the drug distributor and also trusting the health system, adding questions related to that, and also questions related to disability and accessibility of medicines by disabled persons. Thank you.
Thank you, and thanks for all of your engagement on this topic.
So I think Erica or Dr. Clara will present on the next group.
Sure, I can do it. Let me go ahead and share our Easy Retro board. We had some great discussions around some ideas around these populations of people that have never been treated, and that came up a couple of times in our first round. We could hold focus groups with individuals to better understand the barriers to uptake, and also ask them what would encourage them to take the medications. And so we decided that that would be a good use of some qualitative methods. We had an interesting idea that was used in a COVID context, but this was described as photo voice, where participants would, this is a more participant-driven option where participants would take photos and then be able to provide a narrative around why they felt that particular photo was meaningful. And we could do this in the context of MDA. It was just a really interesting sort of new idea. Also, we had a discussion about using qualitative methods to better inform the quantitative questions in a survey, and how focus group discussions could be used to kind of help provide some insights and take advantage of that fast sort of short format of the CES. And I think I'll stop there. Thank you, Clara.
Thanks, Erica. So in the group that I was moderating around the sampling and more broadly methodology, I think one of the approaches that was of interest and that had got a lot of upvotes was around doing a really purposeful oversampling approach where you would really stratify all the villages in a district, and each would have certain qualifications, and then you would sample using that list to have a representative kind of grouping of all the kind of subgroups that you might be interested in. Something else that came up that sort of question of interest is in scenarios where you're doing more subunit MDA, like for Schisto, a 30 cluster design is quite large and cumbersome potentially in a smaller subunit. So what would be a different sampling approach that might be appropriate in smaller geographic and sampling spaces? Also looking, I know, to correlate different kinds of responses and looking at kind of the proxy responses, the missing and non-response, as well as looking at if, this is back to the sort of burden of the survey, if we only had one person in the household responding, how different would our responses be compared to if we had the full household response as we currently have, or some other combination of kind of asking not all the questions to everyone, as is kind of the current model. So I think a lot of great ideas coming out of all these groups. Thank you all for your engagement and participation there. Just have one last slide for our final kind of discussion, next steps. So in the coming weeks, we're going to be working obviously on a session summary as per the usual for core sessions of this nature, and to identify, as we have been discussing, existing and possible future CES enhancements. And as part of that, we'll send out kind of a list summary compile of this conversations as part of an email kind of survey where we might ask you all to participate in ranking potential kind of uses or explorations that we might do, and what the if there's interest also in individuals participating in a larger kind of conversation or working group or other kind of meeting to discuss kind of enhancements to a CES process. And then we didn't talk about this today, but something that we've been batting around on our side, which is, do we need a new name for a survey of this nature? Does it become more than just a coverage evaluation survey, because we're really looking at, household population-based survey around lots of things? And so maybe we maybe it's no longer a CES and maybe it needs a new name. So if anyone has thoughts around that, please share those as well. In the meantime, if you have questions or want to engage more or hear more about the work that RTI has been doing in this space, please reach out to myself or Erica Shoemaker, and our email addresses are here. We have a few minutes for any final comments or questions from the group before we are all sent away to our next activities of the day. All right, well, thank you everyone for joining us today, and we appreciated all of your engagements, and please be in touch if you're interested in continuing the conversation.
Okay, thanks very much.
Thank you.
Thanks, everyone.
Thanks, everyone.
Thanks, Dr. Clara, Joyce, Karthana, and Erica for your support, and thanks everyone on the task force core side for your support as well today. Have a great rest of your day. Cheers.